Non-Hodgkin lymphoma (NHL) is a group of blood cancers that develop in the lymphatic system, the crucial part of the immune system responsible for fighting infections. NHL arises when lymphocytes, the type of white blood cell, grow uncontrollably. These abnormal lymphocytes can accumulate in lymph nodes, bone marrow, spleen, and other organs, impairing the body's ability to fight infections. Unlike Hodgkin lymphoma, NHL does not have the presence of Reed-Sternberg cells, which is a key differentiator between the two types of lymphoma. Types of non-Hodgkin lymphoma NHL includes many subtypes, which are classified based on the type of lymphocyte-involved B cells or T cells and the tumor's growth rate, indolent or aggressive. 1. B-cell lymphoma. Most common diffuse large B-cell lymphoma, the LBCL, the most common subtype, accounting for about 30 to 40% of all NHL cases. It is aggressive but potentially curable. Follicular lymphoma, the slow-growing indolent form of NHL that often remains asymptomatic for years. It makes up about 20% of cases. Mantle cell lymphoma, the rare, aggressive B-cell lymphoma. Burkitt lymphoma, a highly aggressive type, more common in children and young adults. Chronic lymphocytic leukemia (CLL/small lymphocytic lymphoma SLL/CLL) is primarily found in the blood and bone marrow, while SLL involves the lymph nodes. 2. T-cell lymphomas. Peripheral T-cell lymphomas, a diverse group of T-cell cancers, often aggressive. Cutaneous T-cell lymphoma (CTCL) affects the skin, with subtypes such as mycosis fungoides and Sézary syndrome. Anaplastic large cell lymphoma (ALCL), the rare and aggressive T-cell lymphoma. 3. Indolent versus aggressive lymphomas. Indolent lymphomas, slow-growing, e.g., follicular lymphoma, but harder to cure because they can persist for years with minimal symptoms. Aggressive lymphomas, rapidly growing, e.g., diffuse large B-cell lymphoma, but often more responsive to treatment, potentially leading to a cure. Symptoms of non-Hodgkin lymphoma. Symptoms vary depending on the type and location of the lymphoma, but common signs include swollen lymph nodes, painless swelling in the neck, armpits, or groin, fever, unexplained and recurring, night sweats, profuse sweating during sleep, unintentional weight loss, fatigue, persistent tiredness, teaching pruritus, abdominal pain or swelling, if lymph nodes in the abdomen are affected, chest pain, cough, or shortness of breath, if the disease involves the chest or lungs. In some cases, patients may be asymptomatic, and the disease is discovered during routine tests or imaging. Causes and risk factors. The exact cause of NHL is unknown, but certain factors can increase the risk of developing the disease. Weakened immune system. People with autoimmune diseases or those taking immunosuppressive drugs, e.g., after organ transplants, have a higher risk. Infections. Certain viruses and bacteria, like the Epstein-Barr virus (EBV/HIV) and Helicobacter pylori, are associated with some subtypes of NHL. Chemical exposure. Prolonged exposure to chemicals such as pesticides, herbicides, and solvents may increase the risk. Age. NHL is more common in people over 60, though it can occur at any age. Family history. The family history of lymphoma or other cancers can slightly increase the risk. Radiation exposure. Prior exposure to radiation, including radiation therapy, can increase the likelihood of developing NHL. Diagnosis of non-Hodgkin lymphoma. Diagnosis usually involves several steps, including physical exam. The doctor will check for swollen lymph nodes and examine the spleen and liver. Biopsy. A lymph node biopsy is the definitive way to diagnose NHL. The sample of lymph node tissue is examined under a microscope to determine the type of lymphoma. Blood tests. To evaluate overall health and detect abnormal levels of certain cells and chemicals in the blood. Imaging tests. CT scan, MRI, or PET scan, To determine the location and extent of a lymphoma in the body. X-rays. To detect enlarged lymph nodes or masses in the chest. Bone marrow biopsy. NHL often spreads to the bone marrow, so a biopsy may be done to check for this. Molecular testing. Specialized tests may be done to identify specific genetic mutations or markers that can guide treatment, e.g., testing for CD20 on B cells, which can make a lymphoma responsive to certain drugs like rituximab. Staging. The stage of NHL helps determine how far the disease has spread and guides treatment decisions. The Ann Arbor staging system is commonly used. Stage I involves a single lymph node region or a single organ outside a lymph nodes. Stage II involves two or more lymph node regions on the same side of the diaphragm or one organ and its nearby lymph nodes. Stage II involves lymph nodes on both sides of the diaphragm or one lymph node region and an organ on the opposite side of the diaphragm. Stage IV involves widespread disease, including the bone marrow, liver, lungs, or other organs. Additionally, NHL can be classified as A without symptoms or B with systemic symptoms like fever, night sweats, or weight loss. Treatment of non-Hodgkin lymphoma. Treatment depends on the type, stage, and aggressiveness of a lymphoma, as well as the patient's overall health. Watchful waiting. Active surveillance. For indolent lymphomas that are not causing symptoms, doctors may recommend a watch and wait approach. This involves regular monitoring but no immediate treatment, as these types of lymphomas can remain stable for years. Chemotherapy. Chemotherapy is a standard treatment for aggressive NHL, often combined with other therapies. R-CHOP, a common combination therapy for DLBCL, consisting of rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Immunotherapy. Monoclonal antibodies. Drugs like rituximab target specific proteins on lymphoma cells, e.g., CD20 on B cells, and help the immune system destroy them. CAR T-cell therapy, the newer treatment where the patient's own T cells are modified to attack lymphoma cells. This is often used for relapse or refractory NHL. Targeted therapy. Drugs that target specific molecules involved in cancer cell growth, e.g., ibrutinib, which targets the B-cell receptor signaling pathway in some lymphomas. Radiation therapy. Radiation may be used to shrink localized tumors or as part of a combined treatment approach for certain subtypes of NHL. Stem cell transplant. For aggressive or relapsed NHL, high-dose chemotherapy followed by a stem cell transplant, autologous or allogeneic, may be considered. Chimeric antigen receptor CAR T-cell therapy. This is an advanced form of immunotherapy that uses genetically modified T cells to fight aggressive lymphomas that have not responded to other treatments. Clinical trials. Many patients with NHL may consider participating in clinical trials to access new treatments not yet widely available. Prognosis. The prognosis for NHL varies significantly based on factors like the type of lymphoma, stage at diagnosis, patient age, and overall health. Indolent lymphomas, while harder to cure, patients can live for many years, often with good quality of life. Aggressive lymphomas, though more dangerous, aggressive lymphomas can often be cured if detected and treated early. Relapse. NHL can recur after treatment, especially in aggressive forms, but new therapies like CAR T-cell therapy have improved outcomes for relapsed cases. Conclusion. Non-Hodgkin lymphoma encompasses a wide variety of lymphatic cancers with varying levels of aggressiveness. Treatment approaches and prognosis depend on the type and stage of the disease, but advances in therapies such as immunotherapy and targeted treatments have significantly improved survival rates and outcomes for many patients. If you have any more questions or need more specific details about NHL, feel free to ask.